Well, first of all, I want to thank Janine because she has been an invaluable tool for our growth. She has given us information as we needed it, and we've asked her many hard questions, and she's always come up with the answer for us so that we could continue on our journey. So starting off, I want to explain that telemedicine is the piece that connects the rural patient with the specialty provider. I am not a professional speaker, so bear with me. Janine's pushing me out of my comfort zone. And here we go. Ellsworth is a 20-bed critical access hospital located in the middle of Kansas. We have found that telemedicine helps us connect our patients with the specialty care they need without having to travel long distances. Tracy Hansen, before we go any further, helped me write this, and we found it interesting that a lot of the slides that I wrote and she wrote were actually the same on both sides of the equation of this connection. So it was kind of interesting to find that out. But just so you know, throughout the presentation, the originating site is where the patient's located, and the distant site is where the specialty provider is located. There's a little bit of confusion on telemedicine and telehealth. They're kind of becoming used synonymously, but what I'm talking about today is not where a patient can sit at home with their smart device. It's an actual connection with a provider through our facility with assistance from another nurse that can assist the connection and do any vitals and things like that that the physician might need. So why we do telemedicine is because it's the right thing to do for our patients. It improves the specialty care access for them. It reduces the patient travel and stress on families because a lot of times family members have to take off work to take the patient to a specialist. It addresses specialty physician shortages because in rural areas, we don't have the specialists that sometimes are needed. It also reduces physician travel time. If they have outside clinics, outreach clinics, instead of windshield time, they can actually be seeing patients through telemedicine. And the last thing that is a benefit is that it keeps your local patients locally here for ancillary services such as lab and x-ray, so we can capture some of those charges that might otherwise be lost. Patients choose telemedicine for convenience. They'll choose convenience every time, and if it's a good quality visit, the convenience becomes very important. It reduces travel, like I said, for both family and patients. Oftentimes the age or the health makes it difficult for travel, so they can come into our facility instead of traveling an hour or two one way. They can come in locally and see that provider. It also eliminates a lot of lost work time for patients and family. They don't have to take a full day off work or a half a day to attend those. Another surprise that we found is we have shorter wait times. The physician blocks time for their telemedicine visits, and oftentimes we can get a patient in a month or two before what they could physically go see the doctor in an outside community. This is what I presented to the panel at the Help Me Janine, the parity presentation at the Capitol. We had a patient that was about 8, and he was very delayed on his development. Evelyn Nelson was sitting at KU, which is 3.5 hours away from Ellsworth, and had the abilities to help this child. He needed to be seen once a week and sometimes twice a week. Can you imagine being the parent of that child and the provider that you need is 3.5 hours away? We were able to connect Evelyn with this little boy, and he could bop in after school, be seen for 30 to 40 minutes, and be done. And the family didn't have to take off work. It was very convenient. And this actually is a quote from the father of that patient. He has since graduated thanks to Evelyn Nelson and is doing very, very well. We started our pilot telemed program in 2014 when Tracy Hansen called the facility and proposed the program. September 14th was our first visit, and I'll go through that. We were shooting for March, but it took us until September. So you need to allow time for the process. It does take a while. In March of 15, we upgraded our software system and hardware and designated an actual room for the telemedicine visits. We currently have 37 now, specialty providers available. And Hutchinson is growing theirs on the other side as well, and they will soon be adding new providers. Our first step was to determine the number of patients that were being seen by specialty providers. We ran a report out of our electronic health record that could show who went where. That was our first starting point to identify which physicians we needed to try to connect with. Then we identified the key players that needed to be involved. And we'll talk about that a little bit more in the next slide or two. Then we formed a task force to implement the whole process and get it moving. Then we set our timelines, but like I said, our goal was March 14th, but our actual first visit wasn't until September of 14. A capital budget needs to be completed, and grant applications, there's a lot of grants available currently for assistance with the development of telemedicine, and those are something that Janine might be able to help you with. Then you need buy-in from a lot of people. First of all, your medical staff needs to buy into this process. The executive team, the clinical staff, the patient scheduler, and don't forget your IT. On the distance side, on the provider side, it's a pretty easy implementation. All they needed was a laptop or computer with a camera and microphone and a digital platform such as Polycom, Zoom, or InTouch. I am not advertising one over the other, and there may be others out there. Those are just some of the common ones. And then a headphone for the stethoscope. For the originating site, it's a little bit more complicated. We needed a TV and camera, and that's actually our current system in the top left picture. The connection software, the peripherals such as a stethoscope that works within your system, the general handheld camera, which is the bottom picture, and then a digital scope with a lot of attachments with the ear, nose, throat, dermatology, and ophthalmology options. Then a written backup plan if the system is down is very important. And we have step-by-step written instructions in case somebody has to cover. They're inside the cabinet door and somebody can easily walk themselves through how to make a connection. And then of course a maintenance checklist so that you know that the equipment is getting checked on a regular basis. On the originating site, we established an oversight committee right away to evaluate the program and to ensure that we're giving our patients the best quality of care. The clinical staff assists with the actual telemedicine visit. We have an RN in the room to help the physician on the other side with anything he needs. Once you've identified that clinical staff, you'll have to train them and then consider how you're going to grow the program with the staff that you currently have. Right now, we are growing pretty quickly, and we're finding that one nurse in the outpatient area is having a hard time seeing the telemedicine, as well as taking care of the IVs and things like that. So that is something to take into consideration. Next, you need to figure out your scheduling process. The way we do it, the distance site sends us an invite, then we accept that invite and schedule the procedure in our system. And then billing. You'll need to set your charges for the originating site. Ours is $50. We are receiving between $25.35 and $44.74 for that. And then you'll need to refer to the CMS guidelines for billing instructions. They're very easy and simple to understand. On the distance site, Tracy found that it was easy to get the physicians to adopt the telemedicine concept. Not only does it help them meet the patient demands, but it improves their clinical outcomes. It closes the care gaps and also helps meet the goal for value-based care. They have found that it improves engagement with low complexity patient, expands their service lines, and increases their revenue. Through telemedicine, they're able to reach new patients, keep up with the competition, while still lowering their cost. With the parity law passing, reimbursement is currently expanding. Physicians also found that reduced windshield time for them traveling to outreach clinics was very beneficial. For an example, we have a physician from Hutch Clinic that comes in once every couple months. In between those visits, if that patient needs followed up, we're able to do that via telemedicine. One of the physicians there quoted that telemedicine may become a new normal in some aspects of medicine. And he thinks we're going to look back and say what took us so long. For the specialty physician side, they need to consider setting a block of time in the provider's schedule. The doctor and staff will need to be trained on the equipment and run a connection test with each new site. Agreements have to be signed between the facilities, and forms need to be discussed between the two facilities. Connecting the appropriate staff on both sides is also important. They need to have the login credentials, backup instructions, and contract information readily available. It's also best practice to have your IT staff on standby in case there's any technical issues during a visit. The forms that we used and developed for the originating site were the policies for the telemedicine guidelines and credentialing, a contract with each distant site provider, the business associate agreement. We also have job descriptions for the coordinator, the clinical staff, and the technician. And we fax back a survey after each visit. With each visit, we do a patient survey to identify issues immediately so that there are not connection issues that we don't find out until the next visit. It keeps us on top of that. We do an annual survey with physicians to make sure that we're meeting their needs and they are happy with the program. We have developed a welcome packet that we use when we're marketing to physicians, and it gives the things that we can do for their patients. So we tell them the MRIs, the CTs, things like that, that we have available here at Ellsworth County Medical Center for their patients. We also do a telemedicine consent. It's not required in the state of Kansas, but we consider it a best practice. For credentialing, the conditions of participation require that a contract delineates the credentialing process between sites. I am not an attorney, so I'm going to refer you to these two websites to learn more about how to credential. And of course, quality is always important. I report quarterly to the quality committee, and my reports include appointments attended and scheduled. We had quite a few no-shows in the beginning, so I have started calling and reminding 1 or 2 days out, and that has greatly improved, which keeps our physicians on the other side a lot happier. Likelihood to recommend, we only count the top box score. Currently, we are at 100% since the conception of this program, and I think that speaks volumes that our patients appreciate this and see it as a quality way to see their specialty providers. Then we do a quality rating by the nurse that ensures that the provider and the patient's needs are being met, the ease of appointment scheduling for the patient, the quality of equipment performance, the customer complaints and unusual events, which I'm proud to say we have not had any to date since conception, and provider satisfaction and annual survey. Outpatient services captured that might have been taken elsewhere. So I track how many of those outside ancillary charges might have been done by another facility and not kept in-house because we had telemedicine. The Oversight Committee at the originating site reviews the contracts, the job descriptions, the policy and procedures, the quality dashboard, the current provider list, potential providers and specialists, our accomplishments, our software license and renewals, and current medical staff presentation. Every month, we do a current presentation for the medical staff to keep them aware of who is available and who is not on a monthly basis, just to keep it in front of them so they know who they can refer their patients to via telemedicine. Specialty providers, how we have grown that list to 37. First of all, I want to clarify that we give preference to providers that can do direct patient care if needed. If they need surgery follow-up or hands-on care, they can go to that physician and travel if they need to. We've asked our medical staff for their recommendations. We review the referral list from the clinic, and we've had a lot of patient requests. They'll come into my office and ask, I see Dr. John Doe in Kansas City at KU. Can you connect me through telemedicine and save me some travel? As an originating site, it's important to schedule a meeting with the clinical director to gain their support before you contact individual physicians. The contract will be with the clinic and not with the individual physicians, and they're required to keep the credentialing current. So it's important to get them on board first before you go any farther with the physicians. We have found that face-to-face marketing works best. We present the welcome packet and explain how we can meet their needs and the needs of their patients. On the specialty provider side, we follow up with them with a basket of goodies and try to keep the communication open. It's not just a, we got you signed up. It's a continual development of that relationship. And I want you to remember not to age discriminate. Some of our biggest providers are actually specialists that are nearing retirement age. And we'll go into that in a couple slides. For the expansion on the distance side, or the physician side, you want to consider the needs for rural areas and the convenience for their patients and families. This process could also eliminate transportation of a resident of an adult care home. They might be able to just come to the hospital and connect with somebody in KU instead of having to drive all the way to KU. You may want to consider reaching out to facilities and identify what specialty care gaps they have. Explain the convenience for the patient and the benefits to the facility to keep the patient local. With this presentation, I hope it will help you help them with their first steps of implementation. This is an example of a physician that is nearing retirement. He is moving to Kansas City, but he is going to continue to see our patients through telemedicine. So it's been a huge help for our patients because neurologists are limited. And this is what I was talking about with the outreach clinic physicians. Dr. Jeremy Kimke comes in and sees our patients a couple times, like every other month. In between, they might need a follow-up. His nurse practitioner is able to see his patients to follow up, upload the blood glucose levels, and make any recommendations or order any lab or anything like that the patient might need between those visits. So it helps Dr. Kimke meet the needs of that patient, and it helps the patient with the travel. Like I said before, it is important to keep this in front of your medical staff and your patient scheduler. Without them in place, patients may not be aware that they can come to Ellsworth Hospital and not have to drive to see that specialist. We talked about the presentation of current providers at the monthly medical staff. We also have a referral provider guide that we keep current, and I have pencil cups on the physician's desk with all the current providers because it's something that's easy to find, grab, and update as we grow. We also have a commercial, but we haven't been able to get it to play, and I'm disappointed in that. If anybody wants to see it, if they can email me, I'd be more than happy to share that with you. But we have that commercial on our local TV stations, on our website, and on Facebook. We also have website banners. We've had 2 open houses that have been huge for the promotion of telemedicine and very well received. We even had an 80-year-old patient. We had a provider on the other end, and they visited, and she said, wow, that's just like he's in the room, and waved at him as she left. So it's kind of fun to watch how it's not an age-restricted way to see patients. They're willing and like it just as well as somebody very, very young. We have outreach print advertisements and brochures that are distributed throughout, and we keep it on the monthly calendars posted in all patient exam rooms and on the website calendar for events, and printed monthly in the local newspaper. But of course, the best advertisement is always word of mouth. When a patient uses this and finds how convenient it is, they're very likely to tell their friends and family. Our future expansion goals: we would like to be able to see our patients with primary care, urgent care, and possibly school and industry and adult care homes with the handheld devices in the near future, now that the laws are changing a little bit. And Hutch Clinics, since this was a dual presentation, has several new providers that they're going to be offering soon. We have a few tips for success on some of these things we've learned the hard way, but identifying a physician champion is the key. If you can find a provider in your clinic that likes this idea, finds the benefit, and it's easy to sell them on it because there are so many benefits, they will help get the ones on board that are maybe a little bit leery about using telemedicine. Then you need an IT champion, because IT and the connection is obviously very important. We have patients come in 15 to 20 minutes early for registrations. We don't want the specialty provider waiting on the other end. We want it to be a smooth transaction for them. And a lot of times they maybe will have 4 or 5 patients in a row. We can get those patients in and out of that room, and the provider has little downtime. Also, I would suggest that you establish a point person for appointment reminder calls. Like I mentioned before, missed encounters is hard for the provider because they've scheduled that time. So we try to eliminate that as much as possible through reminder calls. Then on the provider's laptop, we learned the hard way, make sure that you test with the equipment they're going to be using. We tested and tested with IT on one physician, and they kept saying, we're connecting, we're fine. And then we'd try to connect with the provider, and we couldn't get the connection to work. What we found out was we weren't testing through his laptop, and he had an older laptop that didn't support the quality of video that we were transmitting. Another important thing that we just learned is to store software passwords where they're still available when there's staff turnover. And one of the biggest with marketing to physicians to try to recruit them into your program, don't take no as a just no. Take it as a not now, because this telemedicine is growing and expanding constantly, and it's being put in front of physicians, and they may not want to do it today, but as they hear other providers talk about it, in a year, 6 months, they may want to consider it to help grow their practices. So don't just take a no as a no. We found a couple helpful resources for you that we'd like to share that give information about how to vet the perfect provider, and there's a MedLearn Matters that is very informative. So Janine, I'll turn it back over to you and let people ask questions.
Great, thank you so much, Terry. That was an excellent presentation. I'm looking at the question and answer box. I'm not seeing any open questions right now, but I'll take a few minutes and let the participants see if they have any questions, and type those into that Q&A box in the Zoom platform, please.
I would also like to share my email while we're waiting. It is TWHTRC agoner@ewmed.com. So if anybody wants any of the forums or anything like that to start from, Ellsworth County Medical Center is always willing to share.
Great, thank you. There is one question from Nancy. She said, well done. Tell us about your demographics of population served.
Well, we're an elderly community. Like I said, we're a small 20-bed facility. So I'm not sure exactly what she means by more demographics. Do you, Janine?
No, that's no, you're right. You know, a lot of our small towns in rural areas are definitely aging, and but at the same time, there are those services that you're providing for children as well.
Yes.
How do you see telehealth in an urgent care setting? That's another question.
Well, we're hoping to eventually, I don't want to market our electronic health record, but within that, there is a way to connect with a patient by their cell phone. But that way, their visit, unlike some of the other where the physician's off in another state, is in our electronic health record. It's captured. We know what happened. The next physician can see what happened with that patient. So there's an ability we just learned within our new electronic health record that we can utilize that to maybe, if a physician's on call, could answer questions. We're just starting to learn about that and investigating what our options could be. More to come on that.
Exactly. Thank you, Terry. I'm not seeing any other questions. Let me check the chat box. No more here. I think you did a great job, Terry, answering everyone's questions, and thank you. Okay, so we have one more question. Do you foresee this expanding across state lines? I'm thinking about specialized cancer centers, etc.
Do you want to field that one, Janine?
Well, you do have to make sure that your distant provider, okay, your provider, the distant site, is actually licensed in the state where the patient is. But I understand how you might be able to want to connect your patients with those providers that they're seeing out of state. But then Terry, you know, then we're getting into the credentialing aspect and making sure that they are licensed. Have you had any experience with that?
I have not. Obviously, my goal would be like the MD Anderson in Houston and St. Jude's, different places like that. I know there's a big facility in St. Louis a lot of people here use, but unless they're licensed in Kansas, we can't connect yet. But I'm hoping they will work on that, opening that up.
Right. CMS is constantly looking at new policies and that type of thing. So that could be something that we could see in the future. I just don't know yet. I do know that there are some compacts in areas, mostly for providers, that states are more and more trying to get into, where there is a nurse compact and a provider compact and behavioral health compact. But there's still more work to be done with that as well. It really is important, especially for those cities that are close to state lines, like Kansas City and Kansas City, Missouri. That it seems to be, you know, something that they really have to work on there. So you're lucky for being out in the middle of nowhere, right, Terry?
Yes, we are. That is a benefit. I would like to recommend Janine. She has just, I can't tell you how much she has helped ECMC with the growth of their program, and that has helped our patient. So I will be eternally grateful for Janine's help. She is very awesome at finding you answers or solutions.
Thank you, Terry. That's a great advertisement for the HTRC. Well, Terry, I don't see any more questions, so if you'll stop sharing your slides, I will make a few announcements about what's going on next. So the next HTRC webinar will be on June 4th. Oh no, I mean, sorry, it will be on July 2nd. July 2nd, 2019, the I Am Healthy approach to rural pediatric obesity. And the presenters will be Megan Murray and Evelyn Nelson. They will give us a great webinar in July. So if you're not at the lake yet, please go ahead and join us. And then in August, we're going to talk about the telehealth technology showcase. We have one more question. Could you please repeat your email address again, Terry?
Yes, it is TWAGONER@EWMED.com. And I apologize, I didn't put that on the slide. And if anybody's on the physician side, if they shoot me an email, I can connect them with Tracy Hansen. She's also very willing to share their program.
Great, thank you. All right, and next, the National Consortium of Telehealth Resource Centers also holds a webinar series, and their next series is going to be on June 20th, and they're going to be talking about school-based telehealth center of excellence. So if you have time to join them on June 20th at 1 p.m. Central Standard Time, you will get to hear an expert in the terms of school-based telehealth. So any questions, please call, visit our website, drop me an email. And if you need Terry's email or you didn't quite get it or you just want to double check, you can drop me an email at jgracie@kumc.edu. All right. I really appreciate everyone's attendance today. Thank you for your participation in this webinar series. If you have ideas of what kind of topics that you would like to hear for the webinar series that we are going to create for the new year, which our new year begins in September for this grant process, please drop me a line and let me know what it is that you would like to learn more about. Again, thank you so much, Terry, for your excellent presentation. Go out and make it a great Tuesday. Have a great June, and hopefully we'll see you back on the webinar series again in July. Thank you so much. Bye.